Hi, nice to see you again. I am Dr. Chengzi the Orange. In our last video, I talked about the early detection and diagnosis of cancer. Today, I'll start talking about cancer treatment. Modern cancer treatment is filled with impressive and often intimidating terminology. Precision therapy, personalized therapy, neoadjuvant therapy, targeted therapy, immunotherapy, proton therapy, brachytherapy, robotic surgery, stem cell therapy, T-cell therapy. These words can easily give patients the illusion that cancer is now easy to cure, or that traditional approaches such as surgery can somehow be skipped. Unfortunately, no matter how advanced the vocabulary becomes, cancer treatment still rests on three fundamental pillars: surgery, radiotherapy, and systemic drug-based therapy. Among those, surgery has long been a cornerstone of cancer care and continues to play a pivotal role in modern treatment. Radiotherapy didn't appear until the late 19th century, and effective cancer drugs came even later in the 20th century. But one of the earliest cancer surgery stories dates back to around the 5th century BC. According to the ancient Greek historian Herodotus, there was a Persian queen named Atossa, daughter of Cyrus the Great. At some point, she developed a lump in her breast. No one knows whether it was truly breast cancer, but the lump kept growing, making the queen increasingly anxious. Then Democedes, a Greek physician and a slave in the Persian court, offered to treat her. There was no anesthesia and no sterile technique. He removed the lump and, remarkably, the queen survived. Grateful, Queen Atossa promised him anything he wanted. Democedes replied, "Please start a war with Greece. I'll join." The queen agreed, but when the army reached Greek territory, Democedes simply ran straight to the Greek side and never came back. What a clever escape. Time passed. About half a millennium later, in the 1st century AD, one of the earliest relatively sophisticated surgical approaches for breast cancer was described by Leonidas of Alexandria. His principle remains relevant today. Instead of cutting directly into the tumor, he began in the surrounding healthy tissue and made stepwise incisions around the mass. After each incision, the tissue was cauterized, a practice no longer used in this form today, to control bleeding and possibly reduce recurrence. The key idea of removing the tumor with a margin of healthy tissue has endured. You may wonder why the development of cancer surgery was so slow. Think about this. Could you drive from Port Orford to Rodantha without a map or GPS? Knowledge of anatomy and the circulatory system is essentially the map for safe surgery. But this map wasn't fully established until after the Renaissance, around the 1600s. From the earliest anatomical theories in ancient Alexandria in the 3rd century BCE, it took humanity more than 2,000 years to finally piece together a reasonably accurate biological map. And that's only part of the story. Anesthesia wasn't introduced until 1846, and aseptic techniques didn't arrive until the late 19th century. Before that, even opening a major body cavity or performing deep surgery was extremely dangerous. Around 1894, cancer surgery reached another milestone. William Stewart Halsted at Johns Hopkins Hospital introduced radical mastectomy. It is called radical for a reason. The procedure removes the entire breast, overlying skin, underlying pectoral muscles, and performs a comprehensive dissection of axillary lymph nodes. This method significantly improved outcomes compared to earlier approaches, achieving a local recurrence rate of around 4%, impressively low even by modern standards. It became the standard approach for breast cancer surgery for the next 70 years. Following Halsted's philosophy, surgeons began applying the same remove-everything-in-one-block strategy to many organs. By the mid-20th century, radical operations for cancers of the lung, stomach, esophagus, liver, colon and rectum, head and neck, cervical and uterus had all been developed and widely practiced. The 1970s and 1980s were a real turning point in cancer surgery. Two surgeons, Bernard Fischer in the US and Umberto Veronesi in Italy, basically asked a simple but bold question: Do we really need to remove that much tissue? Through large clinical trials, they showed something surprising. A much less aggressive approach, just removing the lump, lumpectomy, and adding radiation, worked just as well as the old radical mastectomy in terms of survival. So, same outcome with way less collateral damage. Today, with the development of laparoscopic and robotic technologies, together with advances in neoadjuvant and adjuvant therapies, minimally invasive surgeries are widely used for early-stage localized cancers such as those of the colon, prostate, kidney, lung, and gynecologic organs. Radical surgery is no longer the default. It's now reserved for special situations, such as large, complex, or emergency cases. Surgery is scary. If given a choice, most patients would prefer to avoid it. Unfortunately, nearly 80% of patients with solid tumors will require surgery at some point during their illness. For many cancers, surgery remains the most effective and often the most definitive treatment. Why? Let's imagine the human body as a kingdom and the tumor as a terrorist-seized territory. The main treatment strategies are radiotherapy, surgery, and drug-based therapy, like chemotherapy and immunotherapy. What do these look like in an anti-terrorist war? Radiotherapy is like precision missile strikes, highly localized, targeting a specific area with focused energy. But it struggles to eliminate a large mass of terrorist troops, a big tumor, and has limited effect on distant enemy camps, lymph node invasion. Chemotherapy is more like a full-scale air campaign. It reaches enemies throughout the kingdom, but less selective, inevitably harming some innocent citizens. Even with modern targeted therapy, it is like smart missiles aimed at specific enemies. And immunotherapy, like training the local police and intelligence system, it is still very difficult to completely eliminate all terrorists and reclaim the occupied territory. So what force can truly take back control? Ground troops. Surgery is like sending in ground forces. They enter the occupied area, physically remove the enemy stronghold, tumor mass, and immediately reclaim the territory. They also inspect nearby checkpoints, lymph nodes, for hidden enemy spread, and remove those threats, reducing the risk of future invasion. But surgery does more than clear the battlefield. It brings back critical intelligence. After the tumor and lymph nodes are removed, the tissue is carefully analyzed. Classic pathology uses specialized staining, IHC, to identify cancer cells, count positive nodes, and measure the extent of spread. Modern analysis goes further. Molecular and genetic testing can identify key mutations such as EGFR, BRCA1 and 2, KRAS, TP53, PIK3CA, LRP1B, directly guiding targeted therapy. Tumors can also be analyzed for a range of biomarkers, including DNA, mRNA, and metabolites, which play a crucial role in optimizing immunotherapy. In breast cancer, understanding the hormone receptors, ER/PR, and HER2 status can further guide treatment decisions. It is like when the main terrorists are captured from a terrorist-occupied territory, they are not immediately executed. Instead, they are subjected to intense interrogation by intelligence or military personnel to gather actionable information. The primary goal is to prevent imminent attacks and to map out the broader terrorist network. In this sense, interrogation becomes a crucial step, not just for understanding what has already happened, but for anticipating what might happen next. It is widely considered a helpful and necessary tool for ground maintenance troops or security forces to restore safety, rebuild order, and support long-term development in areas that were once under terrorist control. And even when the cancer is no longer curable or has entered the terminal stage, surgery can still play an important stabilizing role. It may relieve pain, stop bleeding, or clear obstructions, greatly improving day-to-day quality of life. This is similar to a prolonged war against terrorists. Even if complete victory is no longer achievable, ground maintenance troops can still step in to stabilize the situation, resolve resource shortages, prevent ongoing damage, and support local administrative systems. In doing so, They make life much more livable and manageable for the civilians caught in the conflict. I hope to start this part with a personal story. Although I have spent most of my career as a researcher rather than a clinician, I still carry memories from my early medical clinical training that I will never forget. In 1994, I was an intern in the Department of Head and Neck and Oral Surgery. One morning during rounds, the head of surgery arrived with a large entourage, attending surgeons, residents, nurses, visiting physicians, and interns. A visibly agitated patient suddenly stood up, holding a framed 17x 20-inch photograph. He pointed repeatedly at the photograph and then at himself, struggling to speak clearly. "The surgeon told me I had a 50% 5-year survival rate," he said with great effort. "So I took the surgery. Look at me now. Only 6 months and my cancer is back." We stared at him in shock. He had undergone radical surgery for tongue cancer. 2/3 of his tongue had been removed, leaving his speech severely impaired. His left mandible had also been removed, making his face appear shrunken and asymmetrical. His mouth was twisted, his expression almost ferocious. To ensure complete lymph node clearance, surgeons had removed his sternocleidomastoid muscle and part of the pectoralis major muscle. As a result, his head constantly tilted downward and to the left. Scars and pigment changes from surgery and radiotherapy covered his neck and upper chest. He could barely lift his left arm. When we looked at the photograph he held, the room fell silent. The man in the picture was handsome, confident, and full of life. He looked like Elvis Presley. Beside him sat his wife, still young, still beautiful, quietly crying. Even the head of surgery, a man known for emotional restraint, could not hide his compassion. The patient did not survive long enough for a second surgery or reconstruction. Tumor infiltration had made his tissues extremely fragile. 3 weeks later, massive bleeding ended his life. Tragic story. Stories like this force medicine to ask a difficult question. Is removing more always better? As we know, Halsted theory, the more radical the surgery, the better the outcome, has dominated cancer surgery from the late 1890s until the mid-1970s. Why is it challenged and finally replaced by less invasive approaches? Here are the main reasons. First, radical or even super-radical surgery does not necessarily decrease long-term cancer mortality compared to less invasive approaches. In the landmark NSABP B04 trial, led by Dr. Bernard Fisher and initiated in the early 1970s, women were randomized to undergo radical mastectomy, removal of the breast, underlying muscles, and axillary lymph nodes, total, simple mastectomy, removal of the breast only, or total mastectomy followed by regional radiation. With long-term follow-up extending to 25 years, the results were striking. Overall survival was essentially identical across all groups, at around 19–20%. Removing more tissue, and even extensively clearing axillary lymph nodes, did not reduce the risk of distant metastasis or improve long-term survival. By the time surgery was performed, the disease had often already extended beyond what the surgeon could see or remove. Simply making the operation bigger and more aggressive could not eliminate these hidden cancer cells, and therefore could not improve survival. Second, radical surgery had very high morbidity, especially for operations on major organs such as the lung, liver, and pancreas. These procedures were extremely risky. A classic example is pancreatic surgery, the Whipple procedure. In 1950s, mortality rates during and shortly after surgery were often around 20–30%, and in some centers even higher. Third, radical surgery often came at a profound cost. These operations could leave patients with significant disfigurement and long-lasting functional impairment, turning survival into a very different kind of life. Think again about the oral cancer surgery story I mentioned during my internship. Also, for many women treated with radical mastectomy, the impact went far beyond the operating room. They frequently faced physical limitations, such as difficulty raising the arm on the operated side due to muscle removal and scarring. making everyday activities like combing their hair, getting dressed, or reaching a shelf surprisingly difficult. At the same time, the burden was not only physical. Many also experienced deep psychological and social challenges. Changes in body image could lead to a loss of confidence, a sense of reduced femininity, and sometimes withdrawal from social interactions or intimacy. Fortunately, modern medicine has changed the game, allowing surgeons to move from aggressive, radical operations to far more precise and less invasive approaches. So, what made that possible? Of course, we should first thank pioneers like Dr. Fisher and Dr. Veronese, who established a new standard, not only for breast cancer but for many other solid tumors. Take rectal cancer as an example. Earlier surgeries were extremely aggressive. Many patients ended up with a permanent colostomy, an opening on the abdomen with a lifelong bag to collect waste. Today, with a better understanding of anatomy and tumor spread, surgeons can often remove the tumor more precisely, using techniques like total mesorectal excision, and preserve normal bowel function in selected patients. Or take soft tissue sarcomas. In the past, treatment often meant amputation, removing an entire arm or leg, just to ensure no cancer was left behind. Today, with multidisciplinary care, advanced imaging, and modern reconstructive techniques like flaps, we can preserve the limb in over 90% of cases without compromising survival. Second, the widespread adoption of laparoscopic surgery since the late 1980s marked a major turning point. Before that, most cancer operations required large incisions. Patients often experienced significant pain, longer hospital stays, and slow recovery. With laparoscopy, surgeons could operate through several small incisions using a camera and specialized instruments. This minimally invasive approach is now widely used for early-stage localized cancers such as colon, prostate, kidney, lung, and many gynecologic cancers. Compared with traditional open surgery, it typically results in less pain, smaller scars, lower risk of complications, and a much faster return to daily life. Building on this progress, robotic surgical systems further enhanced precision. The first system, Da Vinci, developed by Intuitive Surgical, received FDA approval in 2000. Today, more than 49 robotic systems have FDA clearance in the United States. They are not only safe and at least comparable to existing technologies, but also offer high-definition 3D visualization, tremor filtration, and remarkable dexterity with wristed instruments that can exceed the flexibility of the human hand. This enables surgeons to operate in tight or delicate spaces with greater precision, helping preserve critical structures such as nerves and blood vessels. Third, another major evolution in surgery is timing. If you've watched Breaking Bad, you may remember that Walter White received chemotherapy and radiotherapy before his lung cancer surgery. This approach is called neoadjuvant therapy, which has become a game changer for many cancers, including breast, lung, melanoma, pancreatic, and colorectal cancers. It can shrink tumors, treat micrometastases early, make surgery less invasive, and even give doctors valuable clues about how the tumor responds to treatment. It may sound like an obvious idea, treat first, operate later, but in reality this approach only became widely adopted after the 2000s. Back in the 1990s, I often saw surgeons move straight to the operating room as soon as a solid tumor was diagnosed. Why? One major reason was the limitation of earlier treatments. Early chemotherapy and radiotherapy were quite toxic to normal tissues. They often weakened patients so much that the patients couldn't tolerate surgery afterward. In contrast, today's therapies, like newer chemotherapeutic agents, targeted drugs, and more precise radiotherapy, can shrink tumors effectively while keeping patients in much better condition for surgery. Another key factor is imaging. In the 1980s and 1990s, Connecticut scans had relatively low resolution, often 510 mm slices. MRI was less refined, and ultrasound had significant limitations. Doctors often couldn't clearly tell whether pre-surgical treatments were working. and tiny metastases were easy to miss. I still remember cases during my internship where surgeons opened the abdomen expecting to remove a tumor, only to find that the cancer had already spread widely, forcing them to close without proceeding. Simply put, advances in medicine have improved neoadjuvant therapy, paving the way for minimally invasive surgery. Finally, we should also recognize the quiet revolution in surgical tools. Devices like automatic staplers, vessel sealing devices, harmonic scalpels, argon beam coagulators, and other electrothermal instruments have made minimally invasive surgery safer and more efficient, cutting blood loss, shortening operation time, and improving overall outcomes. Although surgery is the cornerstone of cancer therapy, it still has clear limitations. First, modern medicine views cancer as a systemic disease, which means it often requires a systemic, multi-pronged approach, like chemotherapy, radiotherapy, targeted therapy, immunotherapy, to work together with surgery. Surgery can only remove what we can see and reach. No matter how cleanly it clears the battlefield, its effect is still local. When cancer cells have already spread as micrometastases, that is too small to be detected even by high-definition MRI or PET, surgery alone cannot prevent distant spread or recurrence. Second, not all cancers are suitable for surgery. Blood cancers, such as leukemia, lymphoma, and myeloma, are rarely treated with surgery because they are already distributed throughout the body rather than forming a single removable mass. In these cases, surgery plays only a supporting role, which are mainly for diagnosis or for relieving symptoms, such as airway obstruction or blood vessel compression. Third, for surgery, location matters a lot. Some tumors are simply unresectable. When cancers sit too close to critical structures like the brainstem or major blood vessels, or when they grow in a diffuse infiltrative way, as in glioblastoma, surgery can be too dangerous or simply unable to remove the disease completely. And finally, surgery is far from easy. We've talked a lot about minimally invasive techniques, but in reality, only high-volume centers have access to advanced laparoscopic or robotic systems. In many parts of the world, especially in resource-limited settings, radical surgery is still the only option, often saving lives, but at the cost of quality of life. Some procedures, such as the Whipple surgery for pancreatic cancer, demand exceptional surgical expertise, specialized equipment, and a full multidisciplinary team. Even in developed countries, only a limited number of centers can consistently perform these operations at the highest level. So what is the future of cancer surgery? 1. More precise and personalized. This is the direction of cancer genetics and molecular biology, also the trend of cancer surgery, achieving similar control while reducing bleeding, pain, and disfigurement. 2. Using advanced imaging, like real-time MRI and targeted dyes to help surgeons better distinguish tumors from normal tissue, further improving precision and accuracy. 3. Minimally invasive surgery is becoming even less invasive, moving towards single-port or even scarless procedures with advances in laparoscopy and robotic systems. 4. Robotic-assisted systems are expected to continue advancing, becoming more compact, efficient, and widely accessible. Taken together, cancer surgery is unlikely to disappear. Instead, it will remain essential, becoming more precise, less invasive, advanced technology-guided, and widely accessible. We are approaching the end of this talk. In our next video, we'll focus on another important pillar of cancer treatment, radiotherapy. Thank you for watching. See you soon.